Now, these dopaminergic cells are present in the eye as well. So when you look at literature, there's a lot of interest regarding Parkinson's disease and the retina. So as you can see in the first paper that I've highlighted, this paper actually recommended that idiopathic Parkinsonism disease should be considered as a differential diagnosis for glaucoma in patients who had retinal nerve fiber layer thinning. Now, the second paper is from a neurology journal which said that it wanted to use the peripapillary RNFL as a biomarker to detect the onset and the progression of Parkinsonism. So this led us to our research question, which was, is there a correlation between retinal thickness and Parkinson's? So we recruited 11 patients. So this was 22 eyes of 11 MRI-confirmed Parkinson's patients. These were referred by a neurologist. The important thing to remember here is all these patients, they had no visual symptoms or ocular comorbidities based on the Hohen and the with the structure with the OCT and the retinal structure. We looked at the peripapillary thickness. For the function, we looked at the arterial saturation, the venous saturation, and the AVST. So how did we do the retinal oximetry? So basically, we first start with an oxymap. We take a 570 nanometer red-free image. We mark 2 concentric circles around the optic disc, mask and mark the AV crossings. Then a pseudo-color map is superimposed on it, and the vessel segments are marked. And so these are my results. So when we look at the retinal structure parameters, we look at the PR and FL, which is 103, macular thickness is 274, the retinal functional parameters, the AVS, the arterial saturation, the venous saturation, the AVST, they more or less form within the normal. So we found no significant difference from the normal. So this was important. But when we looked at the levodopa equivalent dosage and the retinal saturation levels, there was an inverse correlation. But the important thing to remember here is all our patients, they were on levodopa and none of them were treatment naive. So it leads us to the question, what is the importance of OCT? So do we do OCT or do we not do OCT? Now there are papers which say that there are significant differences in macular thickness which were detected on SD-OCT in patients with Parkinsonism. As well as there was reduced foveal thickness in patients, but which was not found to be statistically different, but it correlated with the severity of the disease. On the other hand, there have been studies which have said that in patients who had reduction in visual acuity as well as contrast sensitivity, but they did not detect any difference in the retinal thickness. So this is also what we found in our study. The structure and the function did not vary from normal. So the limitations of this study were there was no comparative group of patients who were symptomatic. There were no treatment-naive patients, and we did not look at structural vascular imaging like OCT angiography. So how does this translate into our clinical practice? So before subjecting every patient of Parkinsonism to OCT, we should ascertain its role. So where do we go from here? So there are multiple papers which have been published in Neuro PMC as well as in neurology journals which say that we should look at the electrical activity of the dopaminergic neurons, look at their neurotransmission, and then look for the role of OCT angiography before proceeding with OCT in Parkinson's disease. Thank you.
According to your study, what is the inference is there any use of doing OCT in Parkinsonism?
That's the thing, sir. All my patients were well controlled.
So they were not significantly different from normal?
From normal. So when we went back and looked at literature, we found one study which said that patients, in patients who had undergone after death, they'd actually gone a histopathological examination of the human brain, and they found that patients who were on levodopa, if they were on levodopa, there were no changes. So that meant the patients who were well controlled, that means they were on levodopa, they were found to be significantly normal. So there were no changes from normal.
Okay. Thank you.
Thank you.
Any questions from the audience? Yes, here's one question. There's one question here.
Okay. Do you compare those just see the postmortem is a US study, okay? There are a lot of evidence which layer of okay, and what are the other neurotransmitter with the Parkinson, Alzheimer, yes, which are expressed there.
Exactly.
Okay, you get an idea.
We could have done that. Yes, thank you.
Jayashri, Neuro-ophthalmic manifestations of brain metastasis.
Good evening to all. My 7. Ophthalmic introduction. Metastasis to the brain is the most neuro-ophthalmic manifestations. Secondaries are the most common intracranial tumors in adults. Brain metastases were investigated for primary tumor. It was found that bronchogenic carcinoma 39%, breast cancer 17%, and melanoma 11%. 1,70,000 patients develop brain metastases per year. Aim: analysis of 10 cases with neuro-ophthalmic manifestation due to brain metastasis who presented to our neuro-ophthalmology department in a tertiary eye care center. Out of 10 patients, 8 patients were known cancer patients on treatment. In 2 patients, neuro-ophthalmic manifestation was the initial presentation which lead to the diagnosis of primary tumor. The presenting complaints very defective, they present as the defective vision, diplopia, or headache. For all patients, detailed neuro-ophthalmic examination was done: visual acuity, color vision, central fields, neurological examination including cranial nerves examination, anterior segment, pupil and fundus examination, diplopia and head starting if required, and systemic examination and neuroimaging wherever required. Neuro-ophthalmic manifestations of brain metastasis due to bronchogenic carcinoma. Out of 10 cases, we had 4 bronchogenic carcinoma. Out of 4, 1 case, they present initially with neuro-ophthalmic manifestation. Then we find out the metastasis with the primary tumor together. Case 1, they present with the complaints of defective vision, 6 months duration with best corrected visual acuity, PL both eye. So on examination, they manifest as secondary optic atrophy. In case 2, they present with diplopia. So on examination, they presented as manifested as a right multiple cranial nerve palsy. Case 3, they present as a sudden diminution of vision, 10 days duration with best corrected visual acuity of hand movements both eye. On examination, they manifest as fundus as a chronic papillary edema. The 4th case, which present as an acute 6-nerve palsy, so we ordered neuroimaging, then we find out the brain secondaries as well as the site for primary tumor. So it's contrast enhanced imaging which shows the temporo-occipital metastasis which cause the chronic papillary edema, and cerebral metastasis with edema with midline shift which cause the secondary optic atrophy, and the metastasis involving the clivus and sphenoidal sinuses which cause the 6th nerve palsy. Then coming to the neuro-ophthalmic manifestations of brain metastasis due to the breast cancer, out of 10 cases, 3 cases we had breast cancer on treatment. So case 4, they present with sudden diminution of vision since 7 days. So on examination, we saw the normal fundus and diagnosed as retrobulbar neuritis. And case 5, their complaints present with diplopia since 15 days. They examination, they manifest as left multiple cranial nerve palsies. And case 6, they complaints of headache and pain since 2 weeks. On examination, the fundus shows established papillary edema. So contrast enhanced imaging which shows leptomeningeal carcinomatosis of cerebellum with hydrocephalus which cause retrobulbar neuritis, and cerebral and brainstem metastasis which cause the multiple cranial nerve palsies, and cerebellar metastasis with hydrocephalus which cause chronic papillary edema. Brain metastasis due to chronic myeloid leukemia. The patient present with complaints of diplopia 1 week duration. On examination, it manifests as right 6th nerve palsy. So on neuroimaging, which shows the leukemic deposits involving the right cavernous sinus. Brain metastasis due to hepatocellular carcinoma. It presented as a diplopia 4 days duration. On examination, it manifests as left 6th nerve palsy. So we ordered neuroimaging. The neuroimaging which shows the clival metastasis which caused the 6th nerve palsy. Then brain metastasis due to thyroid malignancy. The 42 years old female patients came with complaints of headache since 20 days duration with best corrected visual acuity was 6/6 both eye, no history of systemic illness. So on examination, the fundus shows established papillary edema. So we ordered neuroimaging, the CT brain which shows the multiple cerebral metastasis with compression of ventricles. So this case we find initially they manifest as a neuro-ophthalmic manifestation of manifestation without known cancer. So we diagnose the brain metastasis along with the primary tumor. tumor together. That is synchronous presentation. So coming to the discussion, metastasis to the brain is the most feared complications of systemic cancer. It may present with various neuro-ophthalmic manifestations depending upon the site of metastasis. Secondaries are the most common intracranial tumor in adults. Cerebral metastasis occurs in 15% of patients with cancer. In 15% of patients, primary remains unknown. In order of decreasing frequency, lung, breast, melanoma, renal, colon cancer are the most common primary tumors metastasis to the brain. Metastatic brain tumor spread by hematogenous spread to the skull bone, from where it spread to the suprachiasmatic space brain, or it directly metastasis to the brain. The location of the metastasis depend about the blood flow to that area. Cerebral hemisphere 80%, cerebellum 15%, brainstem 5%. The most commonly involved gray-white junction. The primary site, first one is the lung carcinoma, then second one is the breast cancer, the second most common cause of brain metastasis. The best diagnostic test for brain metastasis is the contrast enhanced MRI. So for according to the site of the neuro-ophthalmic metastasis, it presents with various neuro-ophthalmic manifestations as optic neuritis, papilledema, optic atrophy, and nerve palsy. The treatment metastatic depends upon the tumor's nature and extent of the primary process, nature and severity of the neurological and visual symptoms. To conclude, brain metastasis should be considered in any patients with ocular symptoms in the absence of intraocular cause, particularly in case of systemic cancer patient. Neuro-ophthalmic to find out the primary tumor, although the treatment is frequently aimed to reduce the symptoms and extend the survival. Thank you.
Thank you.
Thank you, Dr. Can you diagnose the ocular symptom before the primary?
So
In any of the cases,
yes, sir.
you suspected that there is somewhere else is the metastasis, and you refer the patient.
But we had two cases, sir. Two cases. Patients, we first rule out the systemic illness. So then we order neuroimaging, find out the metastasis, sir. The another one
primary
is,
was already diagnosed earlier.
no, two already diagnosed in 8 patients, primary, known cancer patients. But 2 cases, we have, they initially present with neuro-ophthalmic manifestations. We only diagnose the primary site. By neuroimaging, they search for primary site and diagnose the primary tumor.
Okay, thank you.
Yes, my number is 267.
Okay, thank you.
Thank you, sir.
Yes, yes.
Have you done CSF analysis in these cases?
So, no, sir. We confirm the diagnosis with neuroimaging itself. Metastasis itself is causing papilledema and everything. So first we refer all the cases to the oncologist. They themselves start anti-edema measures. They gave steroids and IV mannitol. They control, and then the whole brain irradiation they gave, sir. So no need of CSF analysis, I think so.
Thank you. So next I would like to call upon Dr. Amit Palkar. Dr. Amit, on ocular motility disorders and CNS tuberculosis, from the desk of a systemic ophthalmologist.
So central nervous system tuberculosis, they do present with fever, vomiting, seizures, altered sensorium, but they do also have ocular motility deficits, which are easily overlooked amidst the systemic morbidity. And they're rarely present to a primary ophthalmologist with these complaints, and so these manifestations are underreported. Anti-tuberculous therapy with adjunctive corticosteroids do improve the systemic morbidity, but do they really improve the ocular motility? So the purpose of our study was to study the ocular motility disorders in patients with CNS TV and to study the effect of treatment on them. In a prospective clinical study with over a 24 months duration, after IRB approval and achieving informed consent, we included consecutive cases of CNS TB and excluded the ones which had pre-existing ocular disease or immunocompromised patients. So these patients were referred from the internal medicine and the pediatric medicine department, and when they presented, we took a thorough history, examined the severity of the CNS disease, studied the ocular motility, and we defined impairment of eye movements as a direct manifestation of CNS disease as ocular motility disorders. The internist administered the antituberculous therapy along with adjunctive corticosteroids as per their guidelines. We observed the resolution of OMD, which was defined as absence of subjective symptoms and improvement in the ocular motility. So out of the 22 patients, we had 13 males, 9 female patients with a mean age of 22 years and a mean follow-up of 5 months. Most of them were referrals as papilledema referrals, but we did have 3 patients who presented primarily at the outpatient department who were later diagnosed to have CNS tuberculosis. So half of the patients were in the stage 2 BMRC clinical staging of severity of CNS disease. So out of the 22 patients, 16 patients had nystagmus. Out of 8 of them had pathologic gauge-evoked nystagmus. That's the most commonest one, followed by Bruns nystagmus in 5 patients. The 13 patients had cranial nerve palsy, is the commonest being the 6th nerve palsy. 3rd nerve palsy, there were 2 patients, and 1 patient had combined nerve palsy of the 6th and the 7th nerve. 1 each patient had a horizontal pontine gaze palsy, and 1 with internuclear ophthalmoplegia. So all these findings were not mutually exclusive. All these findings were present in patients, like 3 patients with pathologic gaze-evoked nystagmus had bilateral 6th nerve palsy. 3 patients with Bruns nystagmus had unilateral 6th nerve palsy. The patient who had combined 6th nerve and 7th nerve palsy also had Bruns nystagmus. 9 patients out of the entire cohort had papilledema also associated with it. This female patient who had a 7th nerve palsy along with the right ipsilateral gaze palsy along with ipsilateral 7th nerve palsy. The 15-year-old male who was referred for diplopia, he had hemiparesis, and ocular motility examination revealed he had ptosis with a pupil involvement. So clinically he was diagnosed as Weber's syndrome, which indicated the lesion in the cerebral peduncle, ipsilateral cerebral peduncle, a fascicular lesion. So at follow-up at 3 months after ATT with adjunctive corticosteroids, resolution was seen in 12 patients, which is statistically significant. 6 patients had persistent OMD, but unfortunately 4 patients succumbed to the CNS disease. At 6 months, out of the 12 patients, we lost follow-up of 9 patients, maybe deceased. Out of the 6 patients, 1 achieved resolution. So nystagmus can localize. Studying all these findings, we come to findings that nystagmus can localize lesion, like pathologic gaze-evoked nystagmus indicates that there is a raised intracranial tension, or maybe a lesion which might culminate into it. Bruns nystagmus localizes a large lesion at the cerebellopontine angle, a downbeat nystagmus at the craniocervical junction. Cranial nerve 6th nerve palsy is known as a false localizing sign in raised intracranial tension, but it can have localizing value when it is associated with nystagmus or 7th nerve or 8th nerve involvement with absence of disc edema or pallor. So cranial nerve palsy, when comparison to a non-uniform similar studies, we had a substantial amount of patients with cranial nerve palsy. Sinha et al. Was in their study, they said that cranial nerve palsy are predictors of severe disability and deaths at 6 months. We do have conjugate gaze deficits, like in this patient who had right adduction limitation with left abducting nystagmus, and he had convergence which was absent, seen in suggesting that there was a lesion at the medial longitudinal fasciculus which was rostral. In this gaze palsy, whenever we have horizontal gaze palsy, it directs the lesion to the PPRF, but when we have a ipsilateral 7th nerve involvement, low motor neuron facial palsy, it localizes the lesion to the facial colliculus. So the study did have inherent limitations. It was a small series of patients with a short duration follow-up with high dropout rates. There was a referral bias. But to conclude, identification of ocular motility disorders can localize lesions. Antituberculous therapy with corticosteroids can improve ocular motility, at least in the short term. And correlation of these motility disorders with systemic morbidity is warranted. We do not really see these patients commonly, but they can have resolution of these disorders, and especially in children, they can give rise to strabismic amblyopia as well. These are my references. Thank you so much.
Thank you.
Thank you, sir.
Thank you. Any questions from the audience for this presentation? Okay. So we'll go to the next presentation by Dr. Megha Gulati. 3-dimensional MRI tractography, a boon to localization of visual pathway lesions.
any of the procedures mentioned, with case series, I will be depicting the importance of MRI to of pituitary. Now here we have a 11-year-old male child brought by parents with complaint of diminution of vision in his right eye. Right eye is showing a pale optic disc. Left eye still has an intact NRR. So a MRI was requested. Now MRI is showing a heterogeneous mass in the cella, solid as well as cystic component with supracillar extension and compression of the third ventricle, likely suggestive of a craniopharyngioma. So the first question that the parents ask is that whether my child will regain vision in the involved eye or whether the second eye will get involved or not, which is very difficult to answer with the help of MRI. Now, any tumor or lesion affecting the visual pathway, it may displace the fibers or it may infiltrate them. And both of these have an entirely different visual prognosis. Now, routine MRI, it can very well help us in localization of the tumor, but the location relationship between the tumor and the white matter tracts nearby, the integrity of the white matter tracts, and the localization of degeneration distal to the tumor site, it is very difficult with the help of MRI. Now, it has been shown that the T2 hypersensitivity in the optic nerve somehow correlates with the chiasmal compression, but the degeneration happening posterior to, or the distal to the tumor, it cannot be detected. And this we can detect with the help of diffusion tensor tectography. I will explain this with the help of few examples. Now here we have a pituitary lesion which is predominantly intracellular as shown by a conventional MRI. Now MRI tectography here is showing, here it is showing that the chiasmatic fibers, they are lifted up, as well as there is significant reduction in the density of fibers in the post-chiasmatic radiations on the left side. So whenever there is an intracellular component of pituitary tumor, if we operate early in such cases, at least the vision can be halted or improved in such cases by preserving the optic chiasma in such cases. No, but when the pituitary lesion has a predominant paracellular component, as shown here by conventional MRI, the MRI tractography, the optic chiasma, it is infiltrated by the tumor. The fibers, they are interspersed. So here it is shown first by, this is called splaying up of the fibers on MRI tractography. So here the chiasmatic fibers, they are splayed up. There is decreased density of the left optic nerve fibers, but there is symmetrical density of the optic radiations. So if we operate early in this case, patient is likely to lose vision in the involved as well as contralateral eye because the optic chiasma fibers, they are interspersed. When we will remove the tumors, the chiasmatic fibers, they are going to get affected. Now here we have a third case with 55-year-old female with diminution of vision in both eyes, left more than right, and left eye disc pallor. Conventional MRI is showing a large homogeneous mass in the cella with supracillar extension. MRI tractography is showing the splaying of the optic chiasma fibers and decreased density in the left optic nerve. Now here, a 26-year-old male patient came to our OPD with diminution of vision in his right eye and temporal disc pallor in right eye. Clinically, left eye was normal, but on perimetry, left eye gave us a clue of superior temporal quadrantanopia. So MRI was requested. MRI is showing a large pituitary homogeneous mass with paracellular extension. Here we can see that the right optic nerve, it is involved, the chiasma, it is lifted up, and there is reduction in the density of post-chiasmatic fibers on the right side. So diffusion tensor imaging, it non-invasively evaluates the white matter integrity and fiber connectivity in vivo. So what is the principle is that we detect the water motion in 6 non-collinear directions. In brain, the media is not homogeneous, so water will not move in all directions. It moves parallel to the axons, reason being myelin acts as a barrier, so it doesn't allow the water to flow perpendicular to the axon. And we measure these directions. With the help of measuring the rate and direction of water proton motion, we get 2 diffusion indices. The one is the fractional anisotropy, which is detected with the help of direction of molecular displacement, and mean diffusivity, that is magnitude of molecular displacement. When these 2 data are combined, there is a 3-dimensional reconstruction of the white matter fibers in the brain, and this is what is diffusion tensor tractography is. Now, whenever an orbital tumor, it impresses upon the optic nerve, it may cause necrosis or degeneration of the nerve. Now, whether the degeneration, it is reversible or not, it can be detected with the help of diffusion tensor tractography. Whenever there will be necrosis, there the water proton motion will be homogeneous. It will go in either direction. It will not be the parallel to the axon. So the FA value will decrease. So whenever the FA value is less, there is more chance of necrosis. And this is the color-coded map. Different colors are used for construction of the white matter fiber bundles in DTT. So I can very well conclude that MRI tractography over conventional MRI reliably correlates with visual function in setting of the optic chiasma compression and post-chiasmatic density of the fibers. And it helps in accurate identification of patients who are going to develop visual deficit and therefore require more urgent surgical intervention, as well as it is an important intraoperative guide for surgery also. Thank you.
What is the color coding? You have shown green, red, and blue.
Red. Green is for y-axis and blue is for z-axis. But this DTT cannot help us determine the positive or the negative direction. It just says whether it is x-axis, y-axis, or z-axis. Whether it is in positive or negative direction, this can't be told out.
X-axis means horizontal. Horizontal is green or it is red? Just to show me that again.
So x-axis is red.
Just to show that picture
Please show
again.
it again.
X-axis is red and
Yes, sir.
green is?
Y-axis, z-axis is blue.
Z-axis means what?
So anterior to posterior.
No. That blue means, I think it is a vertical fiber. You just have to see whether there are horizontal fibers from side to side, or anterior-posterior direction fibers. They are that is another color coding. And third color coding is vertical fibers going from cranial part towards the.
So one is from right to left, other is from up to down, and one is from anterior to posterior.
Pardon?
So x-axis red is from right to left,
Right to
y-axis from up to down, and z-axis it is anterior to posterior.
Anterior to posterior.
Yes, sir.
And here that green is what?
So green is y-axis, up to down. Means up to down or down to up, that we can't tell, but y-axis.
No, these are the fibers which are going from anterior to posterior. You can see the optic tract. Down. And if there is a figure in the left side, then you mean
manner where it should be. Degeneration is occurring or necrosis is occurring, but means there is a pathological lesion occurring there.
We have Dr. Zia.
No, I just had a comment
Yes, Dr.
to make.
Zia.
You said conventional MRI includes diffusion tensor. You know the whole protocol, if you go through it,
Okay, ma'am.
it is a part of it. It is
Okay,
not
ma'am.
something that's it's always done, and it's in the positive and in the negative, as sir is saying.
Yes, ma'am.
You know, you've shown the color coding, which makes
Yes,
it
ma'am.
very interesting and impressive.
Yes,
Otherwise,
ma'am.
it's in black and white. It's looking,
Yes,
very
ma'am.
pretty.
Yes,
So
ma'am.
that's the look, that's the
Yes,
display.
ma'am.
But even otherwise, you'll just see that track well on black and white,
Okay.
and it's done both in the positive and in the negative, such that you see in the negative you'll see the cortical matter, and this will come as dark areas, and in the positive you see it. So it's
Okay,
a
ma'am.
part of a whole. When you do a conventional,
ma'am.
so-called conventional MRI,
Yes,
first is
ma'am.
the structure, and this is a part of it.
Okay, ma'am.
So it's not that you have to specially order it. A
Yes,
proper
ma'am.
MRI includes this.
Okay, thank you, ma'am.
Just one point. The interesting fact is that whether you are seeing an ascending atrophy or descending atrophy, that will give a clinical implication of the color coding.
Yes, sir.
Okay, so if it can give a ascending or descending,
Yes.
naturally we are interested for the
Yes.
particular.
Thank you.
Yes, sir.
Did you have an opportunity to study the outcome of the visual at all the patient came back to you after surgery?
Yes, actually we have done 19 patients,
Okay.
10 of them which have been operated.
Okay.
3 were having paracellular component and 4 were having intracellular component. So what I told about paracellular and intracellular were dependent upon my study only.
Okay. Thank you.
Thank you, sir.
Disc.
Good evening, respected judges and my dear friends. I do not have any financial disclosure. Idiopathic intracranial hypertension is a syndrome characterized by blurred vision and other CNS symptoms secondary to elevated intracranial pressure. And the modified Dandy criteria, which basically suggests again presence of these symptoms and elevated CSF opening and CSF. Usually in young to middle-aged obese women with history of taking vitamin A, oral tetracyclines, oral contraceptives, the patients presenting primarily with headaches, blurred vision and marked disc edema, but still presence of a normal visual function and only mild visual field defects. The MRI suggests the signs of elevated ICP, but there are no structural lesions, and the diagnosis is made based on the CSF opening pressure. If we look at the disc edema in idiopathic intracranial hypertension, majority of these patients tend to have bilateral severe disc edema, and even though it might be slightly asymmetrical, but it is not much different in between the two eyes. The disc edema tends to be severe such that the disc appears to be mushrooming by the time patients usually present, though early presentation is not uncommon. If we look at the literature, there are few reports which stress that the disc edema might be significantly asymmetric or might be totally unilateral among patients with IIH and in some of the other previously reported intracranial conditions. So the largest study was by Bidet and others from Emory University, where they described that out of the 556 patients, they found that only 2% of the patients tended to have strictly unilateral presentation and about 3.6% had asymmetric presentation. These patients tended to be slightly older than the remaining patients in their cohort, and they tended to have lower CSF opening pressure. Again, these patients were relatively asymptomatic, and disc edema was found during routine examination. They proposed that it was secondary to the abnormalities of the bony optic canal, with the canal being smaller on the side of the lesser optic disc edema. So with this background, we know that unilateral disc edema in IH is uncommon but possible. However, it still raises concern for unilateral optic neuropathies and is a potential cause of diagnostic dilemma. So we carried out this study to describe the clinical features, presenting diagnosis and outcome of patients with unilateral disc edema in idiopathic intracranial hypertension. We reviewed the records of patients with unilateral disc edema in IH seen from 2009 to 2015. The diagnosis of IH was made according to modified Dandy's criteria. Asymmetric disc edema was considered when there was difference in the severity of disc edema of more than equal to 2 grades, and unilateral was disc edema was said to be unilateral if it was strictly in one eye only and other eye was matching Friesen scale 0. And we included only patients with unilateral disc edema for this study. We collected data regarding the demographics, precipitating factors, the visual function of the patients, visual fields, OCT, neuroimaging findings, and CSF analysis. We also made a comparison with the controls with bilateral disc edema among patients with proven IIH seen during this time. So during this time, we saw a total of 157 patients who had a diagnosis of IIH, confirmed diagnosis of IIH, and of this, only 7 patients had strictly unilateral disc edema, which gives a prevalence of 4.4%, which is similar to the prior studies, but slightly higher as compared, if we compare with the two purely unilateral cases. If we look at the characteristics of these patients, the median age at presentation was 35 years. All patients were females, and right eye was affected slightly more commonly, 5:2. If we look at the presenting symptoms, majority of patients had headache and blurred vision. One patient had TVO, but none of the patients had diplopia or vomitings. And BMI more than 30 kilograms per meter square was seen in only one patient. So only one patient was obese. These are the detailed characteristics of these patients. These are the fundus photographs of the patients, which show that all the patients had strictly unilateral presentation, and none of the other patients had any disc edema. If we look at the visual function of these patients, the visual acuity in logMAR was hovering from 0 to 0.1, that is 20/20 to 20/25, and majority of the patients had mild to moderate mean decibel loss on the HVF. None of the patients had any relative afferent pupillary defect. The visual field analysis showed presence of enlargement of blind spot alone in 4 patients, and 3 other patients had enlargement of blind spot along with superior or inferior arcuate depression. This is a patient representative photograph of patient 6, which showed presence of arcuate defect in one eye and with enlargement of blind spot, and the other eye field defect was secondary to the coloboma. The initial diagnosis was optic neuropathy in 3 of the patients, like papillitis, and 3 patients was thought to be anion or diabetic papillopathy, and 1 patient was thought to have optic nerve sheath meningioma. However, with further diagnosis, further evaluation, we could confirm our diagnosis of IIH. Neuroimaging was on the expected lines, and CSF analysis showed median CSF opening pressure of 28. Rest CSF analysis was normal. All patients were treated medically. None of the patients required any surgical treatment, and this photograph shows a representative case which showed improvement with oral acetazolamide at 2 months and complete resolution by 5 months. And if we compare the patients of unilateral versus bilateral, these patients were, unilateral patients were slightly older. None of them had any vomiting or double vision. The HUF mean deviation was similar, but BCVA was better among patients with unilateral disc edema, and CSF opening pressure was lower. So our series showed that we saw about 4.4% patients, and all were female in our series as compared to the prior report of about 29% being men. The lower prevalence of TVOs and diplopia was seen in our series, and visual function tended to be good among our patients. The limitations are that it was a retrospective study with a small sample size, and we could not gain any data on optic canal dimensions despite trying it. So in conclusion, it's a rare but possible presentation. It often raises concern for an alternative diagnosis and is often misdiagnosed first, but proper workup can lead us to a diagnosis of unilateral disc edema due to IIH, and recognition of this entity is important for appropriate diagnosis and timely treatment. Thank you.
Why the headache was not unilateral disc edema, but what can be the explanation?
I'm sorry, headache? Headache was there in, headache and blurred vision was there in 87% of patients had both of these symptoms.
In other eye also?
No, the blurring of vision was in one eye. Blurring of vision was there in one eye only. It was a symptom which the patient reported from one eye only. And even in the transient visual obscuration patient, patient number 6 showed TVOs, which was strictly monocular. It was not there with the other eye.
It's transient blurring of vision.
Yes. All patients complained, 87% of patients, like 6 out of 7, they complained of headache as well as blurring of vision. 1 patient had transient visual obscurations, which was seen again in the eye which had the disc edema. We did not have any patient with vomiting or double vision. That's what I said.
What can be the possible cause for this?
For the unilateral presentation? Yeah, so there have been previous work, again, the biggest work was done by Samuel Bidet et al. And they tried to look at various things. They tried to look at the presence of any abnormality of the venous sinuses. They tried to look at the optic canal dimensions, and they found that the mean optic canal diameter was smaller on the side which did not have disc edema, or which had lesser disc edema in asymmetric cases. So it's believed that because of the smaller optic canal size, the elevated CSF pressure is not getting transmitted to the back of eye, not to the lamina cribrosa. That is preventing it from swelling.
You did
we tried it actually in a couple of patients, but our radiologist could not focus on getting the optic canal dimensions. We are still trying to do it again for all of our patients.
Just to add a point to it, Mark Cooper-Smith has done a lot of studies on this. So in addition to the optic canal diameter, it's also said that anomalous optic nerve sheaths also will fail to transmit the intracranial pressure into the optic nerve.
That was also one of the explanation, and actually in the other paper they tried this also, but they could not prove it exactly because it's very difficult to prove, but it is also believed that primarily the optic nerve itself is made in such a way that it doesn't get transmitted. But it's a hypothetical thing, it's difficult to prove.
You're doing a CSF opening pressures in all cases of headache and blurred vision in one eye?
Yes, we did CSF opening pressure in all these patients. Yeah, we have that data.
So how do you differentiate this IIH with this optic neuritis, papillitis?
So all these patients had very good visual function at the presentation.
Origin.
So they had normal color vision. None of the patient had relative afferent pupillary defect. Visual acuity was 20/20, 20/25, and visual field defects were primarily enlargement of blind spots. And some patients had superior or inferior arcuate depression. So these things, absence of dyschromatopsia, absence of relative afferent pupillary defect, very good visual function, they tend to rule it out. In fact, for some of the patients we have done even all the patients had neuroimaging and none of the patients showed further other things. But clinically, these are the points that will point out to that it is a elevated CSF opening, elevated intracranial pressure, not a demyelination.
CSF pressure was how much?
Median CSF opening pressure was 28. It ranged from 24 to 30.
24 to 30 centimeter of water.
Centimeters of water.
Okay. Thank you.
Thank you, Dr.
Thank you.
Virendra. Presenters to be present till the end of the session, because the winner of this free paper session will be announced at the end of the session, and please be available till the end of the session, all the presenters. So the next presenter will be Dr. Jayashree on isolated six-nerve palsy, clinical imaging.
Good evening to clinical assessment, role of neuroimaging in diagnosis and management. Inflammation and idiopathic are the causes of six-nerve palsy. Microvascular ischemia is the most common cause of six-nerve palsy, which spontaneously improves time, usually within 3 to 6 months. All this with implications often cannot be excluded neuroimaging. This study highlights the various etiologies of six-nerve palsy and role of neuroimaging, and also we recommend an algorithm for clinical evaluation and need of neuroimaging. Materials and methods. Based retrospective case analysis of 185 neurologically isolated six-nerve from Jan 2016. Inclusion criteria: congenital and acquired isolated six-nerve palsy, and multiple cranial nerve palsy was excluded. For all patients, anterior segment examination including extraocular movements, systemic and neurological examination was done and diagnosed clinically and documented with Hess and diplopia charting. Neuroimaging was ordered wherever indicated if the age of the patient is less than 50 years with or without vasculopathic risk factors, age is more than 50 years without vasculopathic risk factors, presence of neurological signs, presence of fundus pathology, and in presence of trauma. Was analyzed and interpreted. Results: out of 185 patients, males were 132 and females were 53. Age-wise distribution: 50 and less than 50 years were 75 patients, more than 50 years were 110 patients. Was 51 years with male preponderance. We divide the etiologies into ischemic and non-ischemic group. Those patients present with vasculopathic risk factors like diabetes, hypertension, hyperlipidemia, and coronary artery disease are included in ischemic group. In our study, microvascular ischemia, which constitutes 73%, which is the most common cause of isolated six-nerve palsy. So distribution of risk factors in ischemic six-nerve palsy in our study: diabetes constitutes 34.05%, diabetes and hypertension 21.6%, hypertension alone 11.35%, hyperlipidemia 2%, 5.4%, tumors 3.2%, idiopathic 2.16%, infective and congenital 1.08%, and restrictive pathology due to the thyroid-related ophthalmopathy, only one case 0.5%. So coming to the discussion, microvascular ischemic nerve palsy is a presumptive diagnosis of the presence risk factors, clinical presentation and clinical course. It classically presents with an abrupt onset, transitory pain, absence of other neurological findings, and spontaneous resolution over several months. For microvascular ischemic nerve palsy. Other risk factors including hyperlipidemia, coronary artery disease, and left ventricular hypertrophy. In patients of all ages, they found the most common frequent association to be unknown ETR percentage. In contrast, our study revealed a different picture. Diabetes alone constituted 34.05% and hyperlipidemia 3.2%. The reason for diabetes cause higher diabetes in India as compared to imaging. The practice of obtaining neuroimaging for every patient is osteopathic risk factors. So I presented with isolated nerve palsy which shows leukemic deposits in anterior cavernous sinus. Another patient aged 43 years with coronary artery disease underwent neuroimaging which showed preponderant hemorrhage. So these are the few pictures showing the causes of 6 nerve palsy. So majority of the microvascular ischemia nerve palsy resolves spontaneously. So observation, control of systemic condition, close follow-up is necessary. Resolve neurological evaluation and neuroimaging should be done. Diagnosing and exist. Performing neuroimaging for all patients is a costly management practice. In developing country, it may not always be feasible and financially viable. The decision of whether to image or not lies largely with the examining clinician and must be taken on a case-to-case basis depending on the index of suspicion. On the basis of a study, we propose an algorithm for clinical evaluation and need of neuroimaging in isolated nerve palsy. We divide the etiology into ischemic and non-ischemic group. In ischemic group, we ask the patient to rule out their history of cancer. If the patient history of cancer is present, we directly order neuroimaging. If there is no history of cancer, we focus on the age of the patient. If age is less than 50 years with or without vasculopathic risk factors, we go for neuroimaging. More than 50 years, any one of the valuing risk factors is present, then we observe the case, control systemic condition and close follow-up till 3 months. If a resolution occurs, regular follow-up the patient. If there is no resolution, no improvement, involvement of other cranial nerves, we go for neuroimaging. These are my references. Thank you.
Thank you.
Thank you, sir.
Nixon. Functional changes in retina and optic nerve in case of
Is by Professor Goel. I like to go retina and optic nerve in the Alzheimer's disease. So as we all know, Alzheimer's disease is the most common dementia. Vision problems which are normal by Snellen's visual acuity. Changes have been reported in disease sclerosis, Parkinson's disease. Likewise, wanted to evaluate and correlate the structural and functional changes in the retina and optic nerve, and also to look into the association of the structural and functional changes with the Alzheimer's disease severity scoring. So we designed a case control study including 15 Alzheimer's patients, 30 eyes. They had best corrected visual acuity of less than better than 6/9, no treatable ocular diseases, IOP was less than 18, no other cerebral pathologies, and consenting. Exclusion criteria was any macular degeneration, diagnosed glaucoma, non-cooperation for ocular tests. We also recruited 15 healthy subjects as controls, 30 eyes, without any neurodegenerative disorders or history of stroke or cardiovascular diseases, and also consenting. The patients were first, they were diagnosed in the neurology department using MMSE and MRI and PET, and they were referred to us for ophthalmological tests. The 15 healthy controls were also screened using MMSE screening, and then they were also evaluated by the same tests. This was the Washington University Cognitive Dementia Rating Scale, which was used for grading the Alzheimer's patients into a very mild, moderate, and severe dementia. Coming to ophthalmological evaluation, anterior segment, posterior segment examination was done. Then a contrast sensitivity examination was performed using Pelly-Robson charts. OCT measurements for RNFL and ganglion cell was done, and pattern VER and multifocal ERG was done using Metrovision. The ages were comparable as the patients were matched for age. The best corrected visual acuity also was comparable. Surprising was that contrast sensitivity was significantly poorer in the Alzheimer's disease group. Disease duration median was 2.25 years, and cognitive dementia rating scale score showed that the median dementia grading was moderate dementia, and the sum of boxes score for CDR came to be 6.5. So OCT thicknesses, as we can see that in both in RNFL and ganglion cell layer, there was significant thinning in all the quadrants of RNFL and all the sectors of ganglion cell. So this is a diagrammatic representation of all the 4 quadrants of RNFL and the 6 sectors of ganglion cell as we get in the Cirrus machine. So you can see that p-values were significant in all of the quadrants, but the area under curve of the ROC curves were significantly higher in the superior and inferior quadrants. However, in the ganglion cell, all the sectors showed equivalent amount of area under curves, but area under curves were higher for the ganglion cell. Using a cutoff of 77.37, we got a 93.3% sensitivity of the RNFL for predicting Alzheimer's. And in ganglion cell, we got a sensitivity of 90%. So area under curve of a ganglion cell and RNFL were highest in superior and inferior quadrants, and ganglion cell predicted abnormality with a sensitivity of 90% and specificity of 80%. So ganglion cell had a better discriminating ability from RNFL, which has been substantiated by a previous study also. Coming to MFVRG, in all the 3 waves, N1 wave, P1 wave, and N2 wave, we could see that there was a reduction of amplitude and a delaying of the implicit times, and they were significant. They were present from foveola to the parafoveal region, and in a previous study, they have documented that functional abnormality of the outer retina was present in milder stages of AD without any visual impairment. So when we used sensitivities and area under curves for MFVRG and pattern VER, we found that pattern VER amplitude and pattern VER latency had an area under curves of 0.874 and 0.922, which were much higher than MFVRG. So pattern VER had the highest discriminating ability among all of the electrophysiological parameters. Holder et al. In I in 2004 had written that VER abnormality can be present both in optic nerve dysfunction and in macular dysfunction. So macular dysfunction is the one which we are more suspecting here based on the ganglion cell loss. We used Pearson correlation statistic to correlate the disease duration, disease severity with the structural and the functional parameters, and we also used Pearson to correlate the structural and the functional parameters among themselves. So we found that the disease duration correlated well with RNFL, ganglion cell, MFVRG abnormalities. The disease severity by the CDR score, it also correlated well with RNFL and VR amplitude abnormalities. However, no study till date has correlated the ocular test to cognitive scoring. So this is the first data that we have got. And there was significant correlation found between the OCT changes and the electrophysiology also. And pattern VR also correlated well with the multifocal ERG changes. The limitations of the study was a study of prospective, this was just a case control study, so a study of prospective nature can be designed to truly demonstrate the prognostic benefit of electrophysiology and OCT. And we evaluated diagnosed Alzheimer's cases, but we did not include the mild cognitive impairment cases, mainly because these patients we don't get in the hospital setting, in tertiary care settings. Recommendations of our study would be that OCT, multifocal ERG, and pattern VR, they may be developed as biomarkers for preclinical diagnosis of Alzheimer's disease-related visual dysfunction, and these can be quantified as an adjunct to MRI and PET for the diagnosis of Alzheimer's. And non-invasive ocular tests may be compared with other invasive biomarkers like Pittsburgh compound B in the future. So eye tests can be the future of Alzheimer's diagnosis and prognosis, and can be a part of the clinical trials also. Thank you.
VEP.
VEP findings, sir, the P100 wave showed reduced amplitude, and reduced amplitudes were, both of them were significant, but the amounts were not that different.
And multifocal ERG?
In multifocal ERG, P1 and N2 waves, we got reduction in all of the rings from ring 1 to ring 5. And in N1 wave, we could find a reduction of amplitude from ring 1 to ring 3.
And they were correlated with the visual acuity also?
Actually, visual acuity was normal. As an inclusion criteria, we included only those patients who could cooperate for the tests and fix for multifocal ERG and pattern VR. So all of them had subnormal visual loss as we wanted to determine. Their visual acuity was determined as normal, but they had reduced contrast sensitivity, which correlated again with the MFERG reduction. That we had done for the peerless correlation, Pearson correlation, sorry.
They were all on medication?
They were newly diagnosed cases who had been just started from the neurology department under treatment. And then right after starting this project, they were referred to us.
You mean to say the VEP was abnormal in spite of normal visual acuity?
The VEP was coming as abnormal, and the area under curves for VR was higher than the MFERG findings.
In spite of normal visual
In spite of normal vision, yeah.
No, but VEP should go hand in hand. And multifocal, you said that multifocal ERG was also abnormal, VEP was also abnormal.
Actually, the proposal that we want to make from this study is optic nerve dysfunction that we're getting here may be more from originating from the ganglion cells, because there is a pan ganglion cell layer thinning which was seen, and it had a higher discriminating value than RNFL. So as Holder et al, they have the largest review on electrophysiology in eye. So they are of the opinion that both macular dysfunction and optic nerve dysfunction can lead to VER changes. So we are still continuing the study, and we have started doing pattern ERG also for these patients to document the ganglion cell changes.
So you had studied pattern ERG also in these patients?
Pattern ERG we have got, haven't included it in this analysis, but yeah, the study is still ongoing.
But in pattern ERG, you are expecting which wave to be affected in loss of ganglion cells?
P50 mostly, P50 wave.
P50 does not give rise to, P50 is meant for photoreceptors, not for ganglion cells.
P50 is for ganglion cells, sir, and N95 is for optic nerve.
N95 is for ganglion cells. So whenever there is a ganglion cell abnormality, N95 will be the one which will be affected in amplitude.
So we plan to incorporate that data also in future.
How many cases were of severe Alzheimer's?
Severe Alzheimer's patients actually we did not include because the patients could not cooperate for the tests.
Okay.
None of them. Actually, I evaluated 15 patients. I think I evaluated almost 40.
But
and
I think
could
you
not include all
wrote
of
that
them.
only mild cases of this were, it was a limitation of your study.
Yes, unfortunately,
mild
that is a
Alzheimer's.
limitation, yes. Because severe patients are they are so obtunded that they cannot cooperate for the fixation test.
That is what I want to ask. How can you do VEP, pattern VEP, that too?
VEP, these patients, whoever I have included, they could cooperate for the patients.
Yes, sir.
I had to repeat it multiple times. I know MFERG, they would just move their head. So I had to keep on repeating.
It is a corollary to what you said. The point is that when you had, you mentioned that you didn't do it in the very mild cases either. There was a line which said
No,
that
it was done. It was done. It was done, but the median score was 1.
I beg your pardon?
The median score was 1. There are
That is
4
true.
grades,
No,
0.5, 1,
that is
2, and
true.
3.
That is true, but you said that you didn't do it in the very mild cases, the
I
ones who
did.
were probably
Very mild
preclinical
dementia
Alzheimer's.
is not mild cognitive impairment. It's a stage earlier to very mild dementia. So once a patient has very mild dementia, he's a diagnosed Alzheimer's.
Okay, that's
MCI
what.
is preclinical.
So all your cases were cases of diagnosed
Yes,
Alzheimer's.
yes.
But in the recommendation you mentioned that it can be used for preclinical diagnosis of Alzheimer's. So that is
maybe. I said that it may
that
be
is
developed
maybe.
as a
Okay.
biomarker.
Just one input. Apart from RFNL abnormality, there are other cells for Alzheimer. For example, the hemacrine cells, the bipolar cells. They contribute for the Alzheimer. Okay, this is from the histopathology evidence.
Yes.
Again, if you see that controversy of a VEP, pattern VEP, or there is called a functional VEP or a multifocal VEP.
Yes, sir.
Okay, that could be, along with the multifocal ERG, and EDI OCT will give a much more evidence for this.
Thank you so much.
Ankit is presenting. Okay. Presenting author Dr. Ankit Agarwal. Yeah, please. Press syndrome. Winner of the previous free paper session will be presenting for the semi-final now. Press syndrome, an important cause of loss of dynamic instability. Start. Please start.
Good evening. I am Dr. Ankit Agarwal. I am presenting Press syndrome, an important cause of loss of vision in patients with acute hemodynamic instability.
Just hold on. Please reset the timer.
Introduction. Posterior reversible encephalopathy syndrome is a clinico-radiological entity that was well described by Hinchey et al. In 1996. The global incidence of PRESS is unknown. It has been reported in patients ranging from 4 to 90 years of age, with most cases occurring in young age to middle-aged adults. A marked female preponderance is observed, which may reflect some of the underlying causes, the etiology of which are predominantly malignant hypertension, eclampsia, and medical treatments such as immunosuppressive therapy. Majority of cases present with sudden diminution of vision or visual impairment with a normal anterior segment and fundus examination, which does not reveal major abnormalities which are correlating with the visual loss, and thus the diagnosis becomes difficult. Radiologic findings of symmetrical bilateral hyperintensities on T2-weighted magnetic resonance imaging represent vasogenic edema affecting the posterior occipital and parietal lobes. This is the diagnostic criteria of PRESS syndrome, and the management of PRESS includes removal of any offending agents, blood pressure, and seizure management. The aim of the study was to evaluate PRESS syndrome as an important cause of vision loss in patients with acute hemodynamic instability, because the studies done on PRESS, especially in India, are few in number, and more dissemination of awareness is required about it. The period of study was between June 2016 to May 2017 in a multi-specialty tertiary care hospital in Karnataka. The inclusion criteria was patients presenting with complaints of sudden diminution of vision and with associated comorbidities such as acute preeclampsia, eclampsia, severe pregnancy-induced hypertension, and accelerated hypertension. And those patients who had abnormal anterior segment, pupillary abnormalities like relative afferent pupillary defect, fixed non-reactive pupil, and fundus findings which are correlating with the vision loss were excluded from the study. Patients with acute hemodynamic instability like acute preeclampsia, eclampsia, severe pregnancy-induced hypertension, accelerated hypertension, and presenting with sudden visual impairment were examined. Patients falling within the exclusion criteria were not selected for the further study. Grading of hypertensive retinopathy was done by modified Shice classification of hypertensive retinopathy. These are the 5 cases which were examined. Of the age was between 19 years to 43 years, and 4 were female, 1 patient was male. The diagnosis ranged between preeclampsia to pregnancy-induced hypertension, severe preeclampsia, and accelerated hypertension. Blood pressure was, visual acuity and fundus examination was done at the time of presentation, and we can see blood pressure is raised in all the 5 cases. Visual acuity on the time of presentation was, as per patient history, decreased from previous, suddenly decreased to PL positive, PR acquired, and in 2 cases it's even PL negative. And fundus examination was not correlating with the amount of vision loss. Now, all these patients were sent for MRI scanning of brain to find out any neurological cause of visual impairment. T2 and flare hyperintensities involving bilateral parieto-occipital regions suggestive of posterior reversible encephalopathy syndrome. This was reported on the MRI. The antihypertensive medications were started. Blood pressure monitoring and visual acuity recording was done at regular intervals. After 24 to 48 hours of start of treatment, the best corrected visual acuity of all 5 patients was found to be 6/6. The MRI brain repeated 1 week after start of treatment showed resolution of hyperintensities in all the cases, which was correlating with the improvement of visual acuity and blood pressure. Visual fields evaluation using Zeiss-Humphrey visual field analyzer after 1 week of start of treatment was within normal limits in all 5 cases. Now, this is the chart which shows the best predictive visual acuity, which was recorded at regular intervals of 6 hours, 12 hours, 24 hours, and at 48 hours after start of treatment. We can see that it is constantly improving over the time, and by the 24 to 48 hours, in all 5 cases, the visual acuity has improved to 6/6. The same with blood pressure, and we can see that the blood pressure, the decrease in blood pressure is correlating with the improvement of visual acuity. The posterior reversible encephalopathy syndrome is a rare neurotoxic state that presents with altered mental status, headache, seizures, and visual disturbances, along with neuroimaging features of vasogenic edema involving the posterior cerebral circulation. The most common visual abnormality is cortical blindness and blurred vision, which was noted in all 5 patients in this study. But homonymous hemianopia can also occur. These symptoms are thought to result from cerebral edema. The mechanism behind the development of angiogenic edema and MR imaging appearance of PRES is not known. The most widely accepted theory states that sudden deviation of blood pressure causes failure of autoregulation in the cerebral blood vessels, leading to hyperperfusion, breakdown of blood-brain barrier, and vasogenic edema. On MRI, T2 and flare hyperintensities involving bilateral parieto-occipital regions suggest of posterior reversible encephalopathy syndrome. The syndrome is reversible, but early and prompt treatment is required to prevent complications like cerebral infarct, which may lead to permanent visual loss or other sensory motor abnormalities. Early recognition of PRES is important for eliminating factors that cause PRES, such as uremia, hypertension, cytotoxic, and immunosuppressive drugs. It is important for an ophthalmologist to recognize the symptoms and signs of PRES and correlate it to the patient's other clinical findings. Thank you.
What is their source? Decrease in perfusion in the brain, that is a known cause for sudden loss of vision, because it may be seen in any hemodynamic unstable patient. So what is new in this thing? New is only MRI.
Sir, what happens is, sir, like in a multi-specialty hospital, we get calls for references from ICUs and from labor rooms regarding patient having preeclampsia, please come and do fundoscopy. So sometimes out of like one in every 100 patients or so, the patient says that I cannot see since like last 3-4 hours, I'm not able to see at all. But anterior segment findings and posterior and the fundus examination will not be able to correlate at that time. So we have to suspect immediately that this can be a PRES syndrome. If we don't whatever the factors are regarding high blood pressure or renal abnormalities or any drugs which are causing this, some cytotoxic drugs which cause this. So that is why and many ophthalmologists miss these findings. In our hospitals also I have seen some ophthalmologists miss these findings. So it is important to, this information should get to everybody.
Any questions from the audience? Okay. Thank you.
Thank you, sir.
Thank you. So the winner of the second free paper session was Dr. What is presenting? Sagnik Sen. Dr. Sen. Yeah, please, you need to present again for the semi-finals.
Good evening, everybody. I'm going to present on the structural and functional changes in the retina and optic nerve in Alzheimer's disease patients. So Alzheimer's disease is the most common cause of dementia worldwide, and it causes cerebral atrophy. However, the vision is generally said to be normal, evaluated by the Snellen and Acuity charts. The vision is subnormal in the forms of apraxia, Balint syndrome, simultagnosia, and contrast sensitivity loss. Eye is a window into the brain. So we have found eye changes both structurally and functionally in diseases like Parkinson's disease and multiple sclerosis. So we wanted to evaluate and correlate the structural and functional changes in the retina and optic nerve of Alzheimer's disease patients, and also to find an association among those with the disease severity scoring. We designed a case control study with 15 Alzheimer's patients. We included patients who had best corrected visual acuity of better than 6/9 without any other ocular diseases, without any glaucoma, less than IOP, less than 18, and no other cerebral pathologies, and they had to give consent for inclusion. Exclusion was macular degeneration, diagnosed glaucoma cases, non-cooperating for ocular tests. And 15 healthy subjects from RP Center OPD were included, evaluated 30 eyes. They were age matched within ±2 years. They did not have any neurodegenerative disorders like Alzheimer's or Parkinson's or vascular dementia, and they had no treatable ocular diseases. They also had to give consent. The patients were first diagnosed in the neurology department using MMSE screening and MRI and PET, and they were referred to ophthalmology department for evaluation. And 15 healthy controls are also screened using the MMSE scoring. The patients of Alzheimer's disease were rated using the Washington University Cognitive Dementia Rating Scale as very mild, moderate, and severe. In the ophthalmological evaluation, the anterior segment and the posterior segment were evaluated. Contrast sensitivity using Pelly-Robson charts, OCT for evaluation of RNFL and ganglion cell layers, pattern VER and multifocal ERG were also evaluated using the Metrovision MONPAC system. The patients were age matched. Their visual acuity was almost normal and comparable. IOP was also comparable. However, it was found that contrast sensitivity was quite poor, significantly lesser in the Alzheimer's disease patients. The disease duration was median 2.25 years, and the CDR dementia rating scale was 1, which suggested moderate dementia, and the sum of boxes score was 6.5. Coming to OCT, RNFL and ganglion cell layer both showed a significant reduction in thickness in all the quadrants of RNFL and all the sectors of ganglion cell. This is a diagrammatic representation of the 4 quadrants and the 6 sectors of ganglion cell layer. You can see that all the quadrants of RNFL were significantly thinned out, but the area under curve of ROC curves were significantly more in cases of superior and inferior quadrants. However, in ganglion cell, the area under curves were equivalently raised in all the sectors, and they were higher than RNFL. Also, RNFL had a sensitivity of 93.3% and RGCL had a sensitivity of 90%. So area under curve of ganglion cell and RNFL layers were highest in the superior and inferior quadrants. And ganglion cell predicted abnormality with a sensitivity of 90% and specificity of 80%. And ganglion cell had a overall better discriminating ability than RNFL. And this has been substantiated by a previous study by Cheung et al. Coming to multifocal ERG, N1, P1 and N2 waves showed significant reduction of amplitudes and significant delay in their implicit times. Foveolar and parafoveal region abnormality of the outer retina has been detected by MFERG in mild stages of Alzheimer's without any visual impairment by one previous study. Coming to Roc Curve analysis of all electrophysiological parameters, we could see that pattern VR P100 amplitude and P100 latency had an AUC values of 0.874 and 0.922, which was higher than the values of the corresponding MFERG waves, which suggested that pattern VR had a higher discriminating ability than the multifocal ERG, and which has been documented by Holder et al. That VR abnormality can be present both in our optic nerve dysfunction and macular dysfunction, which has been detected already by ganglion cell layer dysfunction. Coming to Pearson correlation, the disease duration, disease severity were correlated with the structural and functional parameters, and the structural parameters were correlated with the functional parameters. So we found that the disease duration correlated well with RNFL, ganglion cell, and MFERG abnormalities, and the disease severity by CDR score also correlated well with RNFL and the VER amplitude abnormalities. However, this is the first study that has detected this data, and no study has been published till date which has got these kind of data. And significant correlation has also been found between the OCT changes and the electrophysiology. And pattern VER also correlated well with the multifocal ERG changes. However, the discriminant function was higher for VER. The limitation of the study was that this study was a case control study and a cross-sectional design. However, a study of prospective nature would be required to truly demonstrate the prognostic benefit of electrophysiology and OCT in neurodegenerative diseases, and especially in Alzheimer's. And mild cognitive impairment cases can also be incorporated in our study to actually quantify them if they can be used as biomarkers for preclinical diagnosis of Alzheimer's disease. And they can also be developed as adjunct to MRI and PET for the diagnosis of Alzheimer's and also for the future treatment. And non-invasive ocular tests like OCT and MFERG, they may be compared with other invasive biomarkers like Pittsburgh compound B and PET scans in future, so that these can be developed as non-invasive alternatives so that they can be easily used in clinical trials or drug trials. Thank you.
Okay, thank you. So thank you all the presenters, and thank you all the audience for staying. The result will be displayed later at the scientific committee meeting. Thank you.